Dr. Christian Cox, and for this case, we're going to be reviewing thoracic 26. And these are acute aortic syndrome cases, so patients that are presenting in the acute setting, generally chest pain, but can be neurologic presentation, can be findings secondary to hemorrhage or secondary effects of dissection. But in general, this is the classic tearing chest pain presentation. So we start with two-view chest with prior on the right and the current on the left in this patient that has chest pain. And one of the reasons I like this case is because the chest radiograph is not terribly impressive. You know, the prior had a tortuous aorta, it had some atherosclerotic calcifications. Here it doesn't look terribly different as far as the atherosclerotic calcifications. The arch isn't terribly enlarged. We don't have any type of evidence of bleed or effusion or anything like that. So this is a fairly similar exam. The chest x-ray does rule out some alternative disease such as pneumonia or pneumothorax or something like that. So basically this is a very similar appearance of the chest compared to prior. But with a classic presentation, the patient went on to a CTA chest. Now I will say that generally the chest CT is obtained with and without contrast. And we do it without contrast because one of the findings in acute aortic syndrome can be mural hematoma. And mural hematoma will show up on non-contrast chest CT and can be difficult to appreciate on a contrast chest CT as being hematoma versus, say, mural thrombus or atherosclerotic disease. So for this case, we've given contrast. We've waited until that contrast has hit the aorta, and then we begin imaging. So the bolus of contrast is in the aorta, and we get down to the aortic arch, and already we can tell that this does not look like the aortic arch that we've seen on other cases, that we've got the central channel of contrast containing aorta. We've got this eccentric thickening of a portion of the ascending aorta, which extends all the way down to the level of the aortic root and the right and non-coronary cusps of the aortic root. And as we go back up to the aortic arch, we see a normal branching pattern, normal contrast-filled branching of our innominate left common carotid and left subclavian arteries. But this portion of lower opacity that's eccentric in the aorta becomes a little higher in attenuation at the distal arch and into the descending aorta. And that's because that's where there is an intimal flap. There is a tear in a portion of the wall of the aorta, and contrast is going through that hole and into and dissecting the aortic wall. Right? As we go inferiorly, we see still the true lumen along the anteromedial aspect and the false lumen, which is partially contrast filled. There may be an additional break or tear distally in the aorta in the descending, and all the way to the inferiormost image on this study. So again, the typical dissection protocol would extend down through the iliac arteries for the full extent of potential dissection. Because this dissection involves the ascending aorta, we call this a Stanford A aortic dissection, and this is a surgical emergency. Right? This patient is treated surgically. If that dissection occurred distal to the left subclavian artery and only extended down the descending from that point, then we would call it a Stanford B. There are some middle ground dissections involving the arch, but I won't get into the details of that. Mainly, I want to show you that this is a Stanford A. It involves the ascending aorta. Other things to be looking for when you've got an ascending aortic dissection is how far down the descending it actually goes, because the extension of the dissection can involve the coronary arteries and cause the patient to have myocardial infarction if you dissect the coronary arteries, and it can also dissect into the pericardium, so with hemopericardium and potential tamponade secondary to hemorrhage. We don't see that in this case. Also, you'd want to note if there's involvement of the branch vessels. Here it does look like there's extension of the false lumen into the origin of the left subclavian, but the carotid and the innominate artery are spared. If this exam went fully into the abdomen, then we would note whether the true or the false lumen provide blood flow to the celiac axis, the SMA, the IMA, the renal arteries, so on and so forth. And also its extension distally potentially into the iliacs. So, altogether, this is a Stanford A thoracic aortic dissection, which does not involve the coronary arteries or demonstrate hemopericardium. Excellent. Thank you.